So hello, I am Kristia Yiangou. I'm a Ph.D. student at the Biostatistics unit of the Cyprus Institute of Neurology and Genetics, and today I'm going to present your work with title Differences in Breast Cancer Polygenic Risk Score Distribution in Individuals from Different European Ancestry Populations and the Implementations for Risk Prediction. Breast cancer is the most common cancer in females worldwide. It is estimated that 1 in 8 women will develop breast cancer during their lifetime. However, the disease susceptibility differs between individuals and is influenced by both environmental and genetic risk factors, which can be used for the prediction of breast cancer risk at an individual's level. And therefore, by identifying women at different levels of breast cancer risk, this could be very useful in guiding targeted preventative strategies. So far, multiple breast cancer susceptibility variants have been identified to be implicated in the disease etiology. Here is a plot which shows the allele frequency versus the relative risk, and as we can see, variants in genes such as BRCA1 and BRCA2 are rare in the population, but they confer high risk of developing the disease. Variants in genes such as CHEK2 and ATM are also rare in the population and they confer moderate risk of developing the disease. And more recently, genome-wide association studies have led to the identification of variants that are common in the population, but they confer low risk of the disease. So individually, these variants cannot be used for the prediction of breast cancer risk. However, their combined effect as a polygenic risk score, the PRS, can be used to estimate the breast cancer risk at an individual's level. So PRS is the weighted sum of multiple common low-risk variants and can be calculated using this equation in each woman. So here, if we plot the polygenic risk score in the population, we will see that PRS can stratify women based on their personal breast cancer risk. And as we can see, most of women have average risk of developing the disease, while a small fraction of the population will have higher risk compared to the average, and another smaller fraction of the population will have smaller risk than the average. Therefore, polygenic risk scores has the ability to identify women at different levels of breast cancer risk, and thus could be very useful in guiding targeted preventative strategies and population screening, reduce overdiagnosis and false positive results. So recently, a 313 variants polygenic risk score has been constructed for the prediction of breast cancer risk in European ancestry populations. Here we can see a 10-year absolute risk plot of developing breast cancer by percentiles of the PRS distribution. So this red line is the mean breast cancer risk for a woman age 47, is the age at which women become eligible to enter the UK breast cancer screening program. And as we can see, while those women that are found here, which have the lowest risk of developing the disease, will never reach this score. Therefore, they have shown that the PRS 313 has the ability to discriminate individuals based on their personal breast cancer risk, and therefore can be a very useful tool to guide screening strategies. So at the moment there is a lot of discussion regarding the transferability of this polygenic risk score in non-European populations, but specific evaluation of this polygenic risk score across the different European populations has not been evaluated yet. So small shifts in the distribution of the polygenic risk score could lead to their classification of some individuals and thus influence their clinical management. Therefore, our aim here is to evaluate the distribution of the PRS 313 in 17 countries of Europe, as well as in Australia, Canada, Israel, and the USA, using data from the BCAG. So more specifically, in this analysis, we have used, the study population is derived from 84 breast cancer case control studies for the Breast Cancer Association Consortium, BCAG. All the samples were previously genotyped using either the ICOX or the OnQuery platforms. And for this analysis, we have used about 112,000 female breast cancer cases and about 95,000 female controls, all derived from 17 countries of Europe, Australia, Canada, Israel, and the USA, and all individuals of European ancestry. So what we have done first was to calculate the PRS-D13 in each individual. Then we have calculated the mean PRS by country separately in cases and controls. And we used linear regression adjusted by array. And finally, we have estimate VI square to measure the heterogeneity in the mean PRS across the countries. Here are the results in the control group. As we can see from the forest plot, which shows the country and the mean and standard error of the PRS, we see that there is a heterogeneity equal to 80%. So the mean PRS differs significantly across the European populations, and is being highest in Greece, Italy, and the Republic of North Macedonia, and lowest in Ireland. As we can see from the map, which shows with darker color the countries with higher mean polygenic risk score, and with lighter color the countries with lower polygenic risk score, we will observe that there is a higher polygenic risk score in East and South Europe, while there we observed lower mean PRS in West Europe. So then we aim to evaluate the distribution of the PRS across the different populations. Here is the distribution of the PRS when we used the pooled dataset. Here in Greece, in Italy, and Ireland, the three countries with significantly different mean PRS. The pink color is indicating the high risk category. And so if we used the cutoff thresholds of the pooled dataset to define the risk categories in Greece, Italy, and Ireland, what we observed that was about 1.3% additional women from Greece will be incorrectly classified in the high risk category instead of the moderate risk category. Similarly, about 0.5% additional women from Italy will be incorrectly classified in the high risk category instead of the moderate risk category. While in contrast, about 1.4% additional women from Ireland will be incorrectly classified in the moderate risk category instead of the high risk category. Therefore, we see that there is a risk overestimation in Greece and Italy, and risk underestimation in Ireland. So what does that actually mean? Here is a hypothetical scenario that a woman, let's say from Greece, goes for risk assessment, is a healthy woman, and if the risk categories are defined based on the European threshold, then this woman will be potentially classified as a very high-risk individual, so she will have probably suggested to undergo from prophylactic treatment. While if the same healthy woman goes for risk assessment and the risk categories are defined based on the Greek PRS threshold, she could probably classified as an intermediate or high-risk individual that will modify her clinical management. Therefore, importantly, we have shown that the genetic background influences the classification of an individual and thus could influence their clinical management. Therefore, before the implementation of the polygenic risk scores in risk prediction, country-specific calibration will be required. Then we aim to explore for potential sources of variability in the mean PRS across the different countries. So we have explored the effects of the ancestry informative principal components. Principal components were previously calculated by Michailidou et al. 2017. Here we have plotted the first two ancestry informative principal components. Individuals from the same country are plotted with the same color and shape. So as you can see, individuals from the same country are plotted together, and this plot shows that there is genetic diversity across the Europe, and if it's not appropriately accounted, could lead to poor results. Therefore, this time, we calculated the mean PRS adjusted by principal components using linear regression. So we also explored the number of principal components that are needed to be added in the model, so the heterogeneity across the countries will be eliminated. We set actually a threshold of I square less than 10% and a p-value greater than 0.05. So here is a plot which shows the I-square versus the number of principal components that were added in the model. As we can see, the I-square was reduced as each principal component was added in the model, and the adjustment by the first 6 ancestry informative principal component almost successfully reduced the heterogeneity across the countries. And here are the forest plot. So as we can see, the observed distribution differences that were also observed before the adjustments were corrected when we adjust the mean PRS by the first 6 ancestry principal components. However, the principal components are not always available since our genotype data are needed to calculate those principal components. So for this reason, we explore an empirical-based approach as an alternative method to derive the country-specific estimates. We have used the method as described in the paper of Clayton and Calder 1987. So this method is based on the logic that the variation in the mean PRS could be actual true variation, but also due to sampling error. Therefore, this method is used to shrink the estimates towards the overall means, depending on the available sample size. So here are the forest plots. Here, when we calculate the mean PRS, and here we calculate the means by using the empirical-based approach. And as we can see, for countries such as the Republic of North Macedonia and Russia, we have small available sample size. Their estimates have the greater shrinkage towards the overall means. Therefore, in this study, we have shown that the genetic background could influence the distribution of the polygenic risk score even within Europe, leading to an underestimation of risk in Western Europe and to overestimation of risk in Southeast Europe, and thus could influence the clinical management of some individuals if it's not accounted for. We have shown that the principal components can correct the distribution differences, while when they are not available, an empirical-based approach can be used as an alternative method to estimate the country-specific means, as it takes account both the true variation and also the sampling error. Therefore, the implementation of the PRS in risk-stratified preventative strategies will require country-specific calibration for more accurate risk estimations and classification. This work is under progress. At this point, I would like to thank Biostatistics Unit of the Cyprus Institute of Neurology and Genetics, and especially Dr. Kyriaki Michailidou for her guidance and support, Breast Cancer Association Consortium, Telethon, and all the people who support us. Thank you very much for listening.